Hey everybody, I don't think my webcam is working right today, so I don't think you can see me in a little corner. Let me switch over to what we're actually going to start talking about. We're actually going to start talking about the principles of pharmacology, or our pharmacology for medical assistants. We're going to do two things in this unit. Not only we're going to talk about pharmacology and the different aspects of that, but you're going to start learning the top 200 drugs. As a medical assistant, there are going to be medications that the doctor's prescribing, that you're going to administer, that you're going to be dealing with, and you need to know what those are because patients are going to be calling and asking about them. You're going to be calling them in. The doctor's going to be giving you orders related to them. So you're going to need to learn those. It's going to take us about 9 weeks to learn the top 200 drugs. And how that's going to work is I'm going to give you a spreadsheet every week starting next week. And you on Monday, I'm actually going to upload it on Friday. Every Friday, I will upload the list for the following Friday's test. So Friday, I will upload a list of the first test will have 29 drugs. The next test will have 21, 22. So you'll have those drugs, and what you'll be learning is the generic name, the brand name, and its classification. So an example would be acetaminophen is the generic name, or APAP is the abbreviation for acetaminophen. The brand name is Tylenol, and it's an analgesic. You'll be learning those three things. So the best thing you can do is make flashcards with those. Like take an index card, cut it in half. On one side, put the generic name. On the back side, at the top, put the brand name. At the bottom, put the classification. And make yourself a ring and keep up with those. These are medications that'll be on the certification exam. So learn them and put them in, hardwire them into your memory, not just for each weekly test. So like I said, it'll take us about 9 weeks. So we won't, we'll cover some of these meds on the semester exam. So let's get started with our principles of pharmacology. So things you need to know. You need to know what pharmacology is. Pharmacology is basically a comprehensive knowledge of pharmacy or medications and how they're formulated, how they're used to treat patients to improve overall health. So that's what pharmacology is. It's the study of the use of medications and formulas of medications to improve overall health of patients. As we go through principles of pharmacology, things we're going to learn about is medication safety, medication law, how they're named, how they're classified, how they're scheduled, what pharmacokinetics are, and that's how the body uses the medication. We're going to learn about medication interactions, and we're going to learn about toxicity. So I want to scroll back up one and talk to you real quick about reasons why you need to know these things. So medication safety, it's important to know about medication safety, not just where it's housed, how it's housed, but what you can keep based on where you work. In a clinic, you can't keep control. You have to have specific ways of storing controlled drugs. There are medications that can't be exposed to light, so they have to be stored a certain way. Some medications have to be refrigerated, like a lot of vaccines have to be refrigerated. Some have to be stored in a powder form. So we're going to learn about why that's important. Medication law, you got to know about the legal aspects of medication, because you don't want to get yourself into a situation, or your provider in a situation where you're breaking the law. Naming, generic, brand name, what the difference is, why everything has a generic and a brand name, and some things are sold as a generic, some are sold as a brand name only. We'll talk about that. Classification, so like we talked about, it's an analgesic, it's a calcium channel blocker, it's a cardiovascular agent. So we'll talk about the different classifications, because you need to know that if a patient is on 2 different cardiovascular agents, it might affect their blood pressure, it might affect their heart rate. So you got to know how the classification of a medication. Also, because you need to know that if a person's allergic to something, say they're allergic to penicillin, well, you don't want to give them Augmentin, because Augmentin has penicillin in it. So those are reasons you understand the classification. Schedules have to do with controlled substances. So that would be like narcotics. There's Schedule 1 through 5, and we'll talk about the Schedules 1 through 5. Schedule drugs are based on their ability or their likelihood to become addictive. And so there are different schedules. And some states have different schedules for certain drugs. Like in the state of Texas, hydrocodone hydrocodone is a Schedule 2 drug, but in most other states, it's a Schedule 3 drug. And we'll talk about what Schedule 2, Schedule 3, Schedule 1, we'll talk about what that kind of means as far as when you're a provider or a provider's support. Pharmacokinetics, once again, how the body utilizes it. Medication interactions, that's something we have to know because sometimes doctors will prescribe medications that have interactions and we have to get with him to make changes. Sometimes we want some of the interactions that medications make, like sometimes we want patients to take a diuretic and a blood pressure medicine together because it will work on their blood pressure better. So we need to know about how interactions impact a patient. And then toxicity. We need to know about toxicity levels because some medications have a very narrow window before they can start doing damage to organs, damage to or damage to other parts of the body. So we want to make sure that we understand how things can affect the system, especially if someone has kidney disease, or they have liver disease. We want to be sure that the medication can actually be processed. So, medication administration is defined as the element of and it says paramedic, and I apologize. I need to fix this because I was typing something for a separate class. Element of clinical practice. So, and I should be having that on the big view, and I apologize for not doing that. So it's the act of giving medication to a patient and to make sure that it has the desired effect that it wants. That's why we give meds. That's why medications are prescribed. We give somebody a medication for it to have a specific outcome. If it doesn't have a specific outcome, then that would be considered an adverse reaction or an allergic reaction. And we'll talk about those two a little later. Severe and often life-threatening consequences occur when people make mistakes. And I apologize when medication errors happen. So just know that we did medical math, and that's one of the reasons that we did medical math is because medication errors really and truly can cause death. We want to make sure that we know what allergies a patient has so that we don't give them something they're allergic to, that we don't give them too much or too little, because giving someone not enough of a medication can be just as serious as giving them too much. So we already talked about what pharmacology is. It's the scientific study of how various substances interact in the body to alter how a body functions. If you have a really rapid heart rate, they may give you a beta blocker because that will slow the heart rate down, and that's why we get the desired effect of it. Pharmacology isn't just about pills. It's about IV meds. It's about herbs. It's about supplements. It's not just things that you get prescribed over the counter. It's things that you take in the hospital. It's things that you may take that are herbal remedies. So pharmacology encompasses all of that. Chemicals have been used, different chemicals, herbs have been used for centuries, for hundreds and hundreds of years, and we still use some of those things today. There are derivatives of them. Digitalis is one of those things. It's a plant, but it's still used today for cardiovascular disease. Formal scientific study of pharmacology began in the 1700s, in the late early 1800s, where we actually tried to look at what medications did and how they interacted and what they would do, and how they could help each other, or how they would interact. And like I said, things like foxglove and digitalis, those are two medications that are from the Incan Indians and even before, that are still used today to make medications. We want to make sure that what we do is evidence-based, though. Evidence-based guidelines assist clinicians in using appropriate pharmacological interactions. So that's why we have the FDA, the Food and Drug Administration. That they go through, a new medication goes through years and years and years of study before it can actually be utilized, or it can actually go into use for the public. It goes through, it has to be registered. It goes through the process of making sure the medication, or the new medication, is pure, the concentration of it. It goes through animal trials. It goes through human trials. And then it goes into a small distribution, and then it goes into large distribution. So it's very specific, the process the FDA goes through to ensure that medications are safe for public consumption. So the United States has a comprehensive system, like I talked about, the FDA. The Food, Drug, and Cosmetic Act was enacted in 1938, and it was what we now call the Food and Drug Administration. It morphed into that over the years, and that's how all medications are either put on or taken off of the market. A medication that I can think of in the last 20 years that's been taken off of the market would be Vioxx. Vioxx is a medication. It's an anti-inflammatory, but that particular medication increased your risk of heart attack. So Celebrex is still sold in a very low dose, but Vioxx is no longer sold because it can cause heart attack. I have a prescription somewhere. It's a picture of a very old prescription for cough medicine, and if I can find it, I will post that up and let you guys see it. But in this prescription for cough medicine, it had morphine, alcohol, I don't know, 3 or 4 things that were in cough medicine that was just sold at the general store in the 17 or the 1800s, that now you can only get in the hospital if you have that medication. So, or you have to be a cancer patient to get some of those medications. So just know that things that were sold widely have been taken off of the market as well. Approval of a medication. Sometimes medications are used, takes many years through human trials, animal trials, human trials, multiple steps that every drug has to go through. But there are medications that we use for other purposes. And off-label basically means that the FDA approved a medication to either be administered a certain way or given for a certain thing, but we use it for something else. One example is Phenergan. Phenergan is a medication for nausea. It's also called, the generic is promethazine. When you go to the doctor or when you go to the emergency room for nausea and vomiting, sometimes they'll give you Phenergan IV, which is in your IV, in the vein. It's not actually FDA approved to be given IV. It's only for IM, PO, or to be given in a suppository. So when it's given IV, it's not really FDA approved for that, but we still can do that. Another medication that's used for FDA purposes that's not what it was approved for would be, oh, my mind just went blank. Sorry, guys. Would be Norvasc, maybe one. Why can't I? Keppra. I'm sorry. The Keppra is the medication I was thinking of. So Keppra is a medication that was initially approved by the FDA for seizure activity. But it was found that in a smaller dose, Keppra can help with migraines. Keppra can help with weight loss. So it's used for those things, but those are not what it was FDA approved for. So just know that there are medications that are used in ways sometimes that aren't necessarily FDA approved. So the Controlled Substance Act, and that classifies medications that have a potential for abuse. There are 5 classes. Over at the right, you are going to need to know that table to the right and some examples of it. So a Schedule 1 drug is basically one that you can't get unless it's in medication trials, like the FDA is doing medication trials, or you can't get it legally. Heroin, marijuana, LSD, PCP, they are not sold legally for human consumption. There's no recognized medical use for them. And they have a huge potential. I mean, pretty much you can use it, and it has a high potential for abuse. Schedule 2 drugs have a high potential for abuse, but they have legitimate medical use. So usually those are a lot of our medications, like fentanyl, which is used for cancer patients as a patch. Ritalin is used as an ADHD medication, but if it's not used by someone who has ADHD, then it can be very addictive, and it's a strong stimulant. Cocaine is another one. Cocaine is actually something that's used in the ER at times when when there needs to be vascular dilation. It's a vasoconstrictor. Sorry, vasoconstrictor. I've used chemical grade cocaine in the ER when a child had something stuck up their nose and it swelled really big and we couldn't get it out, and she stuck a bead up her nose, and it was way up in the nose, almost to where the lacrimal duct is, which is near the corner of your eye. And we used a very small amount of cocaine, blowed that up her nose. It made the swelling go down, and we were able to retrieve that bead. It's not used often, but it is sometimes used. A Schedule 3 has a lower potential, but still has medical use. It can be addictive. So, like I said, in the state of Texas, hydrocodone or Vicodin, it's a Schedule 2 drug. In most states, it's a Schedule 3 drug. Ketamine is a Schedule 3 drug. Tylenol with codeine is a Schedule 3 drug. Let me tell you the difference in the doctor's office for a Schedule 2 and a Schedule 3 drug. In the state of Texas, a Schedule 2 drug has a very specific prescription, or if it's given electronically, the doctor has to do it. A code will go to his phone. He has like 1 minute to put the code in the computer, and then it's transmitted to the pharmacy. A medical assistant cannot digitally, or a nurse, or no one but the doctor can send that Schedule 2 prescription electronically. For the medical assistant, though, working with the physician, when he uses a prescription pad, it's a very specific prescription pad, and you have to keep record of the number on the prescription pad. So if I were to get a prescription for hydrocodone ready for a patient in a separate book, and in the chart, I would have to document the patient's, and you have to write the patient's name, their date of birth, their address, the date the medication can be filled. You have to write hydrocodone 325 milligrams. Then 1 PO 3 times a day number, and you can write the number sign, or as you guys know, the hashtag symbol, 120. Then you have to write out in words 120. I mean, there's very specific guidelines on how that prescription has to be written. If it's not written correctly, if it's altered in any way, if there's any errors made on it, you have to void it and make another one. And you actually have to keep voided prescriptions because they have to be returned to the Department of Public Safety. Doctors in the state of Texas have to have a DPS number, and they have to have a DEA number. Doctors have to have a DEA number just to write any prescription, but they have to have a DPS number as well to be able to write controlled substance for any controlled drug. So that's the difference. The difference is the way the prescription is written. For a Schedule 3 drug, it can actually be transmitted electronically, or it can be faxed over, but it has to have an ink signature. So it can't be a stamp. It can't be a printed like you can't print it off with an electronic signature. You actually have to have an ink signature to fax that over to the pharmacy. Schedule 4 drugs are things like Valium, Ativan, Xanax, those kind of, they have a really low, a much lower potential, but they are still have to be monitored. They still have to go with an ink prescription. A Schedule 4 drug, Schedule 5 drug can actually just be sent as an electronic script without a fax. And that would be like Phenergan with codeine. Indol HD, it's a cough medicine that actually is a Schedule 2 drug because it has hydrocodone in it. But cough medicines like Phenergan with codeine or Histussin with codeine, those are things that can be sent without an ink signature, but they're still a controlled substance. Oh, sorry guys. Okay, so just be sure that you're real familiar with, some examples. Remember that in the state of Texas, even though hydrocodone by the FDA is a Schedule 3, in the state of Texas it's a Schedule 2 drug. That changed in October about 5 years ago. It became a Schedule 2 drug due to abuse. So just be aware of that, and be aware that you have to be very meticulous about your record keeping related to all scheduled drugs. So there are the sources of medication. Medications generally originated from some type of plant. So like atropine, aspirin, digoxin, morphine. Morphine comes from the poppy plant. Atropine comes from foxglove. So those are plants that have been made into specific types of medication that we use every day. Those are medications that are actually non-synthetic. So a synthetic medication would mean that it's made in the laboratory. So now we use plants, we synthetically replicate those plants to make a lot of those medications now. Like hydrocodone. Hydrocodone is a synthetic form of an opiate. But codeine itself is a non-synthetic. Sometimes they're semi-synthetic, so that means part of it does come from a plant or animal, and part of it does come from being chemically engineered. Some examples of animal products: heparin. Heparin is a blood thinner. Thyroid medication, we have to use usually those are synthetic unless it's nature thyroid. Nature thyroid is made more from an animal product than Synthroid. Synthroid is, or levothyroxine, that is a synthetic thyroid hormone replacement. And then there's insulins that the original type of insulin was made from bovine or cow insulin. And now we have genetically engineered insulins. Just depends on what you take. There are different microorganism-based medications. Those would be like our antibiotics. Those are all a derivative of some type of microorganism. And then we have minerals that are natural to the earth that we use in medicine every day: iron, magnesium, sulfur, calcium, lithium. People take lithium for bipolar manic depression, and it must be very specifically and very closely monitored, because the window for toxicity for lithium is very, very small, and it can cause serious issues. Pharmaceutical companies control a lot of things related to that medication: the concentration of the medication, the purity of the medication, any preservatives that are added to it, and any other ingredients, like if it's in a capsule form, if it has to have something added to it to make it compress, to make a pill. They have manufacturing lot numbers and expiration dates. So if you think back to your medical math that we covered, it showed you on those labels that they all have a lot number and expiration date. Because when something reaches its expiration date, we have to discard it. We can't use it after its expiration date. The lot number is important because if something happened to the purity or the concentration when it was being made, or maybe a wrong preservative was put in, or in a recent case, the actual wrong medication was put into the capsule, then you got to know what lot number it was so that they can be recalled. And medications are recalled based on their lot number. Doctor's office get lots of samples, and so if you're working in a doctor's office or anywhere that gets samples that you give out, you have to keep a list of the samples that you give, the number that's in the box, the lot number, and the expiration date. You have to chart that. It's very important that you chart that lot number, and it's in you have it in your sample room, that you have your log for your sample room of what's in your sample room. But also, as you give those samples out, you've got to have that lot number, because if there's a recall, you have to contact the patients and say, we gave you this sample 2 weeks ago. Have you taken this medication because there's a recall on it? So, or you have to let the manufacturing company know that you've given that sample out 2 or 3 weeks ago and who you gave it to. So just be aware that keeping up with the lot number for samples and making sure that you don't keep things that are expired. That's one of those safety things. You get rid of those expired medications that are in the clinic. Forms of medication. So for forms of medication, I really want you to know the first couple columns here. Know what a capsule is. That's a powdered or a semi-solid medication that's enclosed in a cylindrical gel shell. So it's that's what a capsule is. A tablet is a solid medication in a pill form, and it will dissolve either in the digestive system or as it's being swallowed when it gets down to the stomach. Powder is very small, fine particles that can be dissolved and are mixed into a solution to take. Drops are a sterile solution. Usually we think about those for eye or ear drops. They can be sterile or non-sterile, and they can be given either in the eye, the ear, or the nose. And sometimes drops are given to babies as like for a fever. Skin preparation. So sometimes medications come in a gel or an ointment or a paste. There are cardiac medicines that come in a paste that go on. Beta paste is a cardiac medication that you actually put either a half or a whole inch of that over the heart and you let it absorb. Phenergan can come in a gel form. There are ointments that you use for psoriasis or things like that. Suppository is a wax-like material that is given in a body cavity, generally the rectum, but sometimes it's given vaginally, like for a yeast infection. A liquid medication is a medication that's either dissolved or suspended. So when you take a liquid antibiotic, that's generally a suspension, and it's given orally. And then inhalers or sprays. Usually those are related to your lungs. So usually those are either nitroglycerin comes in a spray form or a sublingual tablet for the heart, or it can be an inhaler like albuterol or Zopanex. One of those can be inhaled as a bronchodilator for an asthma-related issues, or sometimes we do steroids that are inhaled for just maybe bronchitis or something for short term. So know the left side of the forms and what type of form that would be, because you may see questions like that. Medication names. So every medication is given basically a chemical name that's used during development. So the chemical name used during development might be like H4C 5 and 3, and that would be sort of like kind of what you learn in chemistry. It will have a chemical name. Then once it's ready to be promoted or to be go through testing or it's completed testing and it's ready to go for human trials, it gets a generic name. That generic name will stay with it forever. And then once it's ready to be sold in the marketplace, sold to pharmacies, sold to patients, it gets a brand name. A medication gets a trademarked brand name, and that can be for 10, 15, or 20 years, depending on their trademark. And then after that, it can be sold as a generic. Now, brand names we know are always more expensive. The generic brand is usually much cheaper because it can be manufactured by multiple companies. When you have something that's trademarked as a brand name and it's that specific name, even things over the counter, like if you buy Tylenol, the brand Tylenol, or you buy Walmart brand acetaminophen, the price is different. So there's a difference in pricing. There's not really a difference in quality necessarily, but there is a difference in pricing. There are some medications two that I can think of right off the top of my head, that if someone starts a generic, they stay on the generic. If they start on a brand name, they stay on the brand name. And one of those would be thyroid for your thyroid. If you start Synthroid, you stay on Synthroid your whole life. If you start on levothyroxine, you stay on levothyroxine. The same thing with Coumadin and warfarin. Coumadin is the brand name, and it's a blood thinner. Warfarin is the generic name. If you start on warfarin, you stay on warfarin. If you start on Coumadin, you stay on Coumadin, because it can change the levels that are in the body, because it may have a little bit of different chemical makeup. Insulins are the same thing. You don't really change up insulins if you don't have to. Oops, sorry. Okay, so references. When we think about what we're going to look at to determine the references for what we're giving, there's no way anyone can know every medication. You just can't, because there are thousands of medications. So you want to make sure that the information that when you have to go look up a medicine, or you have to contact a pharmacy, there are things to consider. Like you don't want to go on the internet, Google the name, and think that that's the right information. There's PDRs, which is a physician's desk reference that has medications listed in it. There are nursing drug books. There are specific drug books and IV medication books and all those kind of things that are specific reference materials. That's what you use. And it really depends on what you need to know. Like, I don't need all of the information necessarily to treat a patient, but the doctor does. I need to know as a nurse that if I give someone, like, here's an example. I need to know that if I'm giving vancomycin, I need to know how it's mixed. I need to know how fast it's supposed to run in. And I need to know that I can't give that with anything else. It has to be given by itself. Normal saline is the only thing it can run with. It is contraindicated, which means don't give it with anything else. That's what I need to know as the nurse. As the doctor, he needs to know what the maximum dose for the day is. He needs to know how many milligrams per kilogram, or how to dose it for the patient. He needs to know if there's a toxicity level. He needs to know what the interactions are. He needs to know how often that particular patient's body can handle taking it. So the doctor needs a lot more in-depth information than I do as a nurse or as a medical assistant. So just be sure that whatever source you're using, if you're looking up a drug, it's a good source. If you're looking it up in your electronic health record, that's usually a really good source, because that's been taken from a PDR or something like that. Another great resource is the pharmacy themselves. We also, when we think about reference sources for patients, we have to think about the cost of the medication and are they able to get it. A doctor can prescribe a medication to a patient, and it might be $100 a pill and they need 10 pills. That's $1,000. If a patient can't afford that, it's our job as the medical assistant, as the nurse, as the patient advocate, it's our job just to make sure that the patient can afford the medicine. If they can't, then we just talk to the doctor and we get the medication changed to something that will work almost about as well. They may have to take 2 medicines instead of 1. Sometimes insurances will pay for things weird, and that's something that as a medical assistant, you're going to run into a whole lot. You'll get what's called a prior authorization from the insurance company, because that's not their medication. You get it a whole lot with insulin. So an insurance might have tiers, tier 1, tier 2, tier 3 in their formulary, but it depends on how much it costs the patient. A tier 1 med doesn't cost them very much. A tier 2 med costs them more. A tier 3 med may cost them quite a bit, and then a non-formulary med may cost them the full price. So say, here's an example of a diabetic med. Say a tier 1 medication is glipizide. Well, that might cost the patient $4. Maybe a tier 2 med would be Invokana, which is another medication for diabetes. It's a pill for type 2 diabetes. That might be a tier 2 med, and it might cost the patient $50 a month. Maybe Farxiga, which is one that is, I'm just thinking about it being on TV a lot lately. Farxiga may be a tier 3 medication, and the patient may have to pay $200 or $300 a month for that. And then maybe there's another medication that's new, brand new, and it's non-formulary. And that medication might cost the patient $1,000 or $1,500 a month. So we have to know, that's our job, is to know or to figure out or to help the patient make sure that they can get what they need. How available is it? We need to know all those kind of things. Also, we need to make sure that our resources and our information is up to date. Drug books are updated every year, and then every month they will, if you bought a Lippincott drug book, when you buy that and you register it, or you register for that, then you will get an update once a month in your email with new medications, and you can print that out, fold it, stick it in your drug book, and you have that available. If you're working somewhere that has a drug book that's 10 years old, ask for a new one. They should be giving you access to a new drug book every year. They just should. Okay, so medication monograph, or the medication profile. It's going to give you a lot of information. It's something that is in the USP, and a PDR has all of this on it. It's also in an insert in every medication box, and it talks about the medication names, the generic, the brand name. It talks about the classification or the category of the medication. Is it an antibiotic? Is it a narcotic? Is it a Schedule II drug? It's going to talk about pharmacodynamics, its mechanism of action. Where does it start working? Does it start working when it is dissolved in the stomach? Does it start working when it's dissolved in the rectum? Does it have to pass through the liver to start working? How does it and when does it work? It talks about pregnancy risk. So that's another thing we have to know, or we have to be thinking about and looking up if we have a pregnant patient. There are medications that a patient that's not pregnant can take, that once they become pregnant, we have to get them off of it. There are blood pressure, even as simple as a blood pressure medication. There are blood pressure medications that you can't take if you're pregnant. So there are different pregnancy risk factors and pregnancy categories that you have to think about. Contraindication, that means don't give the medication with another medication. It tells you what available forms it's in. Does it come in PO, IV, IM, sublingual? And so what I mean by that is, an example is Levaquin. Levaquin is an antibiotic. So Levaquin, the medication name would be Levaquin or levofloxacin. It is an antibiotic or an anti-infective. It's for infection, for serious infections. It can be given IV or IM. It cannot be given during pregnancy generally in the first trimester. It comes, like I said, IV, IM, or IV or PO. The normal doses are 250 or 500 milligrams a day. It should be given over 30 minutes if it's IV. If it's PO, it should be given the same time every day. It is incompatible with a ton of things, like caffeine is one. Adverse reactions could be tightness in the chest, rash, tightness in the throat, shortness of breath. Those would be adverse effects. And the pharmacokinetics basically means how long does that medication stay in the body before you need to take it again. So that would be what would be on a monograph for Levaquin. So that's all of the things on that monograph. that, and like I said, that's what the same thing as that package insert that's in every, when you have samples to give, inside that little sample box will be that monograph. And most electronic health records have monographs that you can print off. If you get medications from the pharmacy, normally you get a monograph from them as well. They're just on the outside of your prescription. So, like I said, those are just things that you need to make available and tell the patients they're in there, and they can be, please feel free to read them. Sometimes when they read them, they'll freak out because they'll think that they can't take it or anyway, but it's in there for them. Hospital pharmacies often have formularies too, so sometimes you can call the pharmacy. There are medications that are only given in a hospital as well, so you just need to be sure that, an example, generally most clinics don't give morphine in a clinic generally. That's generally just given in a hospital, or in an ambulance. That's an example of something that the American Medical Association has evaluated and said that is not something that should be given in a clinic setting, but should be given in a hospital setting. So just know that there are meds that you only give in either an emergency vehicle or in a hospital setting. So medication storage. We have to be really careful with medication storage. We have to be sure we understand that when we store a medication, it has to be in a certain we have to take special precautions. So first off, you want to make sure that your medications are housed appropriately. So a lot of times we will have a med cabinet, in a locked med cabinet in the clinic that has things that we administer regularly, like Celestone or Kenalog. Toradol, we give Toradol. They'll give Toradol a lot in the clinic. They'll give, sometimes we'll give antibiotics. Sometimes we will give, trying to think what we gave often. Sometimes we give steroid shots. Like I said, sometimes we give hormone injections. So we know that female hormone doesn't have to be locked up, but if we're going to give testosterone shots in the clinic, that's a growth hormone. That's a controlled substance. It has to be locked in a separate locking box, and it has every drop of it has to be accounted for. We have to give the patient's name. We have to give the lot number, the date, how much we administered. I mean, it's very specific. It's one of those scheduled drugs that we may be administering in the clinic, but we have to be very careful about our documentation. We also want to make sure that if it needs to be refrigerated, it's refrigerated. We need, in the state of Texas, the Department of Health requires that medications be locked up and not be easily accessible to patients. So if you keep certain things in the patient's room, they have to have a lock and key. It prevents damage. It prevents people from hurting themselves. Also, some medications have to be protected from light. So we have to make sure that we don't store them even where the light, like they're stored in a specific packaging that prevents light from getting to it. Vitamin K is one of those. It has to be in a very specific, it's a really, really thick dark brown Ziploc bag that the vitamin K goes in, because light will break it down. So those are just, like I said, some examples of ways that we've got to store medicines. Another thing is we don't want to store Kenalog next to Ketotolac. Ketotolac is Toradol, and Kenalog is a steroid. So we don't want an anti-inflammatory and a steroid together where we could grab the wrong thing. They're also both in a small dark brown little individual vial. So making sure that our storage cabinet is labeled and that we don't keep things that look alike, sound alike next to each other. Those are important things for medication storage. We also want to make sure if it's out of date, we get rid of it. Controlled substances, like I said, have to have additional security, additional record keeping. If you dispose of a controlled substance, maybe some doctors do keep testosterone as an example. They'll keep testosterone in their clinic and they may give it to patients once a month or once a week. It has to be in a separate locking box. It has to be, like I said, you have to account for the patient, the time, the date, how many milliliters you gave, how many milligrams it is. You have to have the order written, and then once you're done with it, you have to lock it back up. If for some reason it goes out of date or the bottle gets cracked, then on a multi-dose vial, the bottle gets cracked. You and the doctor and another person have to acknowledge, have to document that it's been disposed of. So like in the hospital when I worked in the emergency room, and I would give morphine, it came in a 1 milligram, it came in a 1 milligram or a 10 milligram vial. Well, if I was ordered to give 7 milligrams of morphine for someone having a heart attack, I had to dispose of 3 milligrams of that. Someone had to sign off for me with that I had disposed of it. And we had to document together that I had disposed of that because that's a Schedule II drug. So like I said, there's very specific disposal regulations. Once again, you got to document what you give. If it's going to impact the patient, you also have to reevaluate the patient. Like if you're giving them a blood pressure medicine, you need to check their blood pressure again. Controlled substances, the people will tamper with them. People that they know they're there, and it's not necessarily patients. Sometimes it's people you work with. So you want to be sure that you look at a vial. Testosterone is clear, but it's really kind of oily and thick, and it moves really slowly in the jar or in the vial. You want to make sure if it's a multi-dose vial, it doesn't move like water, because if so, someone has tampered with that. So you want to make sure that the lids, if it's a single-use vial, that the lids haven't been popped off of it. You want to make sure that it's in the condition it's supposed to be in. If it's not, you want to report it to your supervisor, report it to your doctor, and get that taken care of. The physiology of pharmacology. So that's, once we administer the medication to produce the desired effect in the body, there's something called pharmacodynamics. And that's pharmacodynamics basically means how a medication alters the body. And can there be a toxic effect at what point? So pharmacodynamics would be, I have a headache and I take Advil. Pharmacodynamics is when I take that Advil, how does it affect my brain to make me not have pain? Or how does it affect my back? If my back is hurting, how does it affect the inflammatory process, and how does it make the pain go away? And how long does it work? And how much can I take without it being too much? So ibuprofen is given at 10 milligrams a kilogram. And if you give more than that, it can cause toxic effects to the liver and kidneys. So those are examples of how pharmacodynamics work. The process of giving a medication, what happens with the body, where does it absorb? How does it absorb? When is it distributed? So I take a medication. Say I'm going to take my Advil liquid gels, and I have some maybe in my purse. But I forget my webcam is not working right for some reason. I'm not sure why. It's not picking up on this right now. But I take my liquid gel, and when it goes into my stomach, that gel cap opens up and it is absorbed in my intestine. Then in my small intestines and in my stomach, and then it is sent to my liver, where it is then it's distributed through my circulatory system, and it goes through my liver, where biotransformation happens. Biotransformation in anything taken orally happens in the liver. The liver breaks down what I can't use and sends out what I can, and then what I can't use, I get rid of either by urinating or having a bowel movement or sweating. That's pharmacodynamics, the action of the body on the medication. What happens with it? Okay, let me see. How long have we been talking? Okay, guys. So I'm going to take for just a little bit, and I'm sorry. We're going to stop here for today. And I'm going to go ahead and give you your first set of drugs. I want you to take the rest of the time today. We'll pick up tomorrow with the principles of pharmacodynamics, because we just kind of touched on the base of it. This, you're going to look at this, and then there's a lot of information in this. It's okay. It's a lot of what you do related to medications as a medical assistant. So I'm also going to give you I'm going to give you your list of first portion for your top 200 drug test, and it's going to be the top 200 drugs, letters A and B. And we're going to go in alphabetical order. Sometimes it's just easier and it makes more sense. So that will be what you do with the remainder of your class period. So please be sure that you are being prepared, because next Friday, which is the 7th, you will have a test over these first 29 drugs, the A and B. And test questions may be, I may ask you, acetaminophen is also known as, and I'll give you options for a brand name. Or I may ask you, acetaminophen is which of the following: an analgesic, an antibiotic, a calcium channel blocker, and you have to tell me which one it is. It could be true, false. It could be multiple choice. So be sure that you learn these as we go. All right, you guys have a great day, and I'll be back with you soon.